So my topic of interest will be pathophysiology of diabetes mellitus. So as the name suggests, how I have planned this, I will be discussing on how our blood glucose is maintained at a normal level and what happens if your blood glucose is increased, which is causing the hyperglycemia, and one of the causes is going to be diabetes mellitus. So my specific learning objectives will be, I will be discussing on this order. So we all know diabetes mellitus is because of defect in insulin secretion, or insulin will be secreted but it is not going to act. So what? And two types of diabetes are there. Type 1, absolute insulin deficiency, insulin is not coming at all, beta cell is not secreting insulin at all. Type 2 is insulin is secreted from beta cell but it is not able to act on its receptors or any target for that matter. So I will be telling how the beta cells are releasing the insulin, which is physiology, and once that insulin is released, how it is going to act. Insulin action on carbohydrate metabolism, protein metabolism and fat metabolism. Remember, diabetes mellitus is not only abnormalities of carbohydrate metabolism, very important, it is also involving fat as well as protein metabolism. When I discuss on pathophysiology of diabetes mellitus, obviously obesity has to come because it is also one of the causes, one of the main causes, and when obesity and consequences of obesity comes, it results in metabolic syndrome. So I will be touching upon what are the components of metabolic syndrome. Liver acts as a buffer in maintaining the blood glucose. So there are 8 mechanisms which results in causing the diabetes mellitus. So these 8 mechanisms put together is called as omnIOS octet. So that I will be discussing. In fact, most of the complication diabetes mellitus is due to abnormalities in fat metabolism. There is another hormone, glucagon, which is also important in maintaining our blood glucose. So if you ask what are the hormones involved in maintenance of blood glucose, tell both insulin as well as glucagon. Insulin decreases your blood glucose, glucagon increases your blood glucose. So they both have to balance each other to maintain your glucose homeostasis. If that glucose homeostasis is disturbed, it results in diabetes mellitus. The pathophysiology only I am going to discuss. So you can see here, whenever your blood glucose is increased, insulin is secreted from beta cell. So your blood glucose is maintained. For example, I am eating 4 idli. So what happens? My blood glucose will increase and that glucose will enter into the beta cell. So the stimulus for beta cell to secrete insulin is glucose. So what happens? When your glucose is increased, that glucose via GLUT2 transporter enters into the beta cell. As the glucose enters, ATP increases. As ATP increases, these potassium channels are closed. For the closure of potassium channels, I require ATP, and ATP is coming from glucose. Simple. So whenever glucose is more, potassium channels are closed. Whenever potassium channels are closed, calcium channels open. As the calcium channels open, calcium enters. Entry of calcium causes release of insulin. Very simple. So this is the mechanism of insulin secretion from beta. So this has to function properly. Since I am discussing pathophysiology, please remember the word incretins, which we also call as GLP-1, glucagon-like peptide. GLP-1 are nothing but it is secreted from gastrointestinal cells. So whatever we eat, products are coming into the GIT. So remember, for example, if I take 4 idli, 6 idli, what will happen inside the GIT, gastrointestinal tract? Incretins are secreted. That incretins will be there whenever there is increased glucose here. When there is glucose increase, at the same time, incretins are also increased, and this incretins also helps in release of insulin. Please remember, it does not directly act on the beta cell. It is going to act on the GI epithelial cells, and incretins will send signals to the beta cells. That you should remember. These incretins are usually inhibited to maintain the homeostasis. It should not be too much also. So these incretins will be inhibited inside. There is enzyme called DPP4, dipalmityl phosphatase, DPP4. So the function of that enzyme DPP4 is to control these incretins. In diabetes, what happens? Blood glucose is high. So what I should do? Incretins should be more or less? Yeah, incretins should be more because incretins helps in release of insulin. I want insulin. I am suffering from diabetes. So I use a drug which inhibits DPP4. And what DPP4 inhibition does? Increases incretins. Very simple. This is the structure of insulin receptor IR. 2 alpha units and 2 beta units connected by disulfide. Once insulin binds with insulin receptor, what happens? There is a trigger of pathways which occurs inside the target cell. So this is a cell membrane where insulin is acting. Common target tissues for insulin are adipose tissue, skeletal muscle, liver. It acts on all cells, but these 3 are the main targets. For example, if I take this as skeletal muscle, so what happens? Insulin is binding, and you can see here tyrosine kinase is activated. As tyrosine kinase is activated, IRS, insulin receptor substrate, will be activated. So because of this activation, because of these pathways, glucose will be entering into the target organ. That's what we want via GLUT4. In beta cell it is GLUT2. The glucose entering into the beta cell is via GLUT2 transporter. The glucose entering into the skeletal muscle or adipose tissue into the cell, that is via GLUT4 transporter. That you should note it down. So glucose enters into the GLUT4 only if insulin is acting. And please note it down, the insulin, apart from glucose utilization, note it down. Insulin is an anabolic hormone. So insulin helps in protein synthesis, fat synthesis and the growth and gene expression. So when diabetes can occur? Yeah, when there is problem in tyrosine kinase. So what will happen? These further pathways will not occur. Or when there is problem in IRS, insulin receptor substrate, what will happen? This glucose cannot enter inside. So glucose cannot be utilized and hyperglycemia will be there. If IRS is not functioning or tyrosine kinase is not functioning or IRS is not functioning, what is the term called? Yes, it is called as insulin resistance. Insulin resistance is one of the common causes of type 2 diabetes mellitus. If I take type 2 diabetes mellitus, which is insulin resistance, it is not only carbohydrate abnormal. Just now I told insulin is anabolic hormone, fat synthesis. So if insulin is not functioning, yes, hyperglycemia is blood glucose is increased, no doubt, because glucose is not taken by the cell. But what happens to the fat? Insulin, what it does? Fat synthesis. But here insulin is not working. So fat breakdown. See here, abnormalities of fat. Fat will be converted to fatty acids. More fatty acids, acidosis. What will happen to protein? What insulin does? Protein synthesis. Correct. If insulin is not working, protein breakdown. So what will happen? Decreased ability to synthesize proteins, which will cause muscle wasting. That is one of the common causes of, we see excess loss of weight in uncontrolled chronic diabetes. Sometimes patients will come, doctor, for the past 6 months I have reduced 5 kg, I have reduced 10 kg. Immediately we have to suspect diabetes because muscle wasting will be there in uncontrolled diabetes. In fact, you can even see here atherosclerosis, which is one of the abnormalities of fat metabolism. Triglycerides may increase. Because of this increase in triglycerides, atherosclerosis can occur. That can also cause death in diabetes. So remember, diabetes mellitus is not only abnormalities of carbohydrate metabolism, it is also involving both fat as well as protein metabolism. Yeah, now coming to regulation of blood glucose by insulin. Glucagon is the hormone which increases blood glucose. So they both act as counterparts. So they both have to maintain a balance, which I told. Liver acts as a buffer. Whenever the blood glucose is decreased, what pancreas does? Alpha cells will increase glucagon because glucagon increases blood glucose. Here, glucagon increases glucose production from liver. What insulin does? Insulin will inhibit glucagon. Insulin will take the glucose into the muscle. Insulin will be secreted from beta cells of pancreas. Yeah, whenever the blood glucose is increased, insulin increases. Whenever the blood glucose is decreased, glucagon increases. So blood glucose is maintained not only by insulin, it is a balance between insulin and glucagon. So pathogenesis of diabetes. Can anyone answer what are these entire components? So obesity, insulin resistance, dyslipidemia, glucose intolerance, hypertension, decreased adiponectin. Can anyone try to answer? I will give you a time. All these are the components of metabolic syndrome. So if a patient, why I want to tell all these together is mostly if he is obese, definitely will be suffering from insulin resistance. That's what I want to say. And if he is having insulin resistance, most of the cases of insulin resistance will be suffering from dyslipidemia. Obviously, insulin resistance is going to have hyperglycemia, glucose intolerance will be there. And if he is going to suffer from dyslipidemia, his BP is expected to increase, lipid abnormalities. So hypertension can occur. So if you are obese, it is most common that you will end up with all this: obesity, insulin resistance, dyslipidemia. So diabetes causing dyslipidemia, we call the term diabetic dyslipidemia, DD, diabetic dyslipidemia. And what I have planned is I am going to go step by step. For example, I will take obesity. I will tell how obesity causes insulin resistance. Once you end up in insulin resistance, how it causes dyslipidemia. So if I discuss these three, it is almost the pathogenesis of diabetes will be little bit clear. Why insulin resistance can end up in dyslipidemia? Insulin causes fat synthesis. If insulin is not functioning, fat breakdown. Fat breakdown, one of the products of fat breakdown is triglycerides. Increased triglyceride, that is called dyslipidemia. And adiponectin is a good anti-inflammatory molecule. If that is decreased, it is dangerous for our body, and that is also included as one of the components of metabolic syndrome. Yeah, I can understand Sir, you are telling obesity causes insulin resistance, obesity causes insulin resistance. Next question, how? Yeah, obesity, what is obesity in general? Excess body fat. And whenever there is excess fat, what we expect of fatty acids? Fatty acids are breakdown products of fat. So when there is more fat, we expect more fatty acids. And that excess body fat also releases adipokines. Adipokines are dangerous. Adiponectin is good, anti-inflammatory. Adipokines are inflammatory. Very, very simple. So whenever there is more fat or whenever there is more fat than normal, more fatty acids. Now this is very important. See here, free fatty acids interfere with insulin signaling. Note it down, free fatty acids interfere with insulin signaling. I already discussed mechanism of insulin, how insulin helps glucose entry into the cell. IRS pathway is disturbed. The slide which I put, entire thing is gone. So glucose cannot enter via GLUT4 into the liver or into the adipose tissue. In fact, in liver it is GLUT2. In adipose tissue and skeletal muscle it is GLUT4. Now need not bother as GLUT2 or 4. Insulin cannot function properly because IRS pathway is affected. Why IRS insulin receptor substrate pathway is affected? Free fatty acids are interfering with insulin signaling. I don't want to go into that molecular mechanism. Insulin receptor substrate is affected. IRS pathway is affected. That causes insulin resistance. When there is insulin resistance, it results in hyperinsulinemia. In slide is very important. Just see here. There is insulin resistance. What will happen? Fat metabolism. I will give some time. You just please try to answer. Insulin resistance. What will happen to fat metabolism? Insulin is not acting. So lipid production or lipid breakdown? Lipid breakdown. So lipolysis occurs. When there is lipolysis and there is fat breakdown, what will happen? More free fatty acids. Yeah, but this insulin resistance came because of increase in free fatty acids. We saw free fatty acids interfere with IRS. So what I want to say is, here free fatty acids, interfering, which causes insulin resistance. That insulin resistance causes, so it is like a cycle. So it keeps on. So unless you either decrease your body weight or correct that IRS, the cycle going to keep on go. Maybe I should have mentioned here, free fatty acids causes insulin resistance. Insulin resistance causes fat breakdown. Fat breakdown again increases free fatty acids. Very simple. Free fatty acids causes increased insulin resistance. Increased insulin resistance causes hyperglycemia. Again it causes fat breakdown. So the cycle keeps on going, and hyperglycemia results in type 2 diabetes. Type 2 diabetes is insulin resistance causing hyperglycemia. Yeah, but I don't think now the audience will be like this because I already told the answer for this. How insulin resistance causes dyslipidemia. If you know the physiology, that's what physiology is very, very important. If you know the physiology, pathology is obviously going to be very easy. Pathophysiology is the what we are discussing. So when there is insulin resistance, fat metabolism is disturbed. We all know insulin causes fat synthesis, but here insulin is not functioning, so fat breakdown. Very simple. See here, why high triglyceride? Fat breakdown. What is triglyceride? Triglyceride is fat breakdown. Yeah, this point I wanted to remember. Free fatty acids combine with glycerol to form TG, triacylglycerol. When free fatty acids are more, when there is fat breakdown. When there is fat breakdown, when there is insulin resistance. When there is insulin resistance, one of the causes is obesity. So the cycle again continues. Yeah, triglyceride is more. This triglyceride is mainly formed in liver and adipose tissue. So hypertriglyceridemia, which occurs in insulin resistance, and hypertriglyceridemia is one of the components of metabolic syndrome. So I discussed obesity causing insulin resistance causing triglyceridemia, hypertriglyceridemia. If there is more blood, when insulin is less, what will happen to blood glucose? Glucose is not being taken inside the target cell by GLUT4 or GLUT2. So glucose is increased, blood glucose is increased. So there is a possibility of de novo synthesis. De novo synthesis is formation of triacylglycerol from glucose. So what happens? The high blood glucose can stimulate the liver. Glucose is not utilized. It is not taken by the cells, but it can be utilized for the production of more triglycerides. And that more triglycerides coming from the glucose is called as de novo lipid synthesis. These increased triglycerides can deposit in the blood vessels, which can result in atherosclerosis. Because already I told you, in diabetes mellitus, it is abnormalities of fat metabolism also very, very important, not only carbohydrate. Just to concentrate this normal circadian rhythm of insulin, or in our 24-hour cycle, how the insulin is here. This is breakfast, lunch, dinner. At breakfast, okay, you can see a biphasic insulin secretion. Just to concentrate, after breakfast, insulin is increasing. Why? You can see here, this grey color is prandial insulin, that is basal. The insulin secretion will be maintained throughout, but suddenly you can see here the insulin is increased. Maybe after breakfast you can see here, the time is not given here, this is 24-hour profile, maybe 9 a.m, this is around 1, this is around 8 p.m, breakfast, lunch, dinner. Why insulin is increased? Obvious, when glucose is increased, what will happen? That glucose will enter into the beta cell. What beta cells does? Release of insulin. So insulin is released, and it is usually biphasic, immediate release, then slow release. Immediate release of insulin is already the insulin are stored in the form of vesicles, that will be immediately released. Then the insulin has to be formed from the beta cell and get stored into the vesicle and then released. That's why always the first release is very fast, the second release will be little bit slow. This is called as biphasic insulin secretion. Arrow mark from 9 p.m. to next day morning or up to this is basal. So always our circadian rhythm has to be maintained. So our insulin secretion after or otherwise night from 9 p.m. to next day 8 or 9 a.m. your insulin secretion should be basal, should be maintained. Now what happens? For example, imagine this is 12 a.m. At 12 a.m. what is insulin secretion? Basal, no increase, no increase. But if I eat at 12 a.m. what will happen to my blood glucose? Blood glucose increases. Then what will happen to insulin? Insulin has to be at rest at 12 a.m. but my blood glucose is increased. So what happens? Beta cell starts secreting insulin, or I am giving overload to the beta cell, which should not done. Workload should not be given during night time especially. After 8 p.m. to 9 p.m. better try to avoid eating. That's what they said, at late night we should not eat anything. At late night we should give rest to insulin. Very, very important. That's what I want to discuss. Yeah, insulin is telling don't disturb me. Yeah, in Tamil will tell Tungar Singata 30 ilpading. So don't wake up the sleeping here. This lion is insulin. So insulin is taking rest for next day to act. Next day breakfast, your glucose increases, insulin should come from the beta cell. But what we are doing here? Night time itself, 12 a.m. itself you are eating means beta cell starts functioning very early. You are not allowing the beta cell to sleep. Imagine you are not sleeping for 2-3 days. Whether you will be able to active? Even if you are not able to sleep one day, next day you will not be able to function properly. The same thing holds for insulin also. Insulin is also a hormone which is working to maintain your blood glucose, to do all the metabolism. If you are not allowing insulin to take rest, that is not good. So please remember, don't disturb the insulin during night time. So don't eat at night time. Try to finish your dinner as early as possible. Very, very important point which I want to discuss. Why not to eat at late night? Very, very important. Never eat at late night. Never disturb your insulin at night. Never make the beta cells release extra insulin at night time, that the insulin be basal. So liver acts as a buffer in maintaining your blood glucose. If glucose is more, that glucose will be converted to glycogen in liver. If glucose is less, gluconeogenesis will take place, formation of glucose from non-carbohydrate source. That also occurs in liver. So liver acts as a buffer to maintain your blood glucose. So when there is insulin deficiency, what will happen? Fats are more broken down, because that fats will be converted to more fatty acids, more triglycerides, more deposition in the blood vessels, atherosclerosis can occur, coronary artery disease can occur, diabetic ketosis, DKA, usually DKA. Diabetic ketoacidosis is common in type 1, but in type 2 diabetes also, if it is uncontrolled type 2 diabetes, your blood glucose is more than 500, then there is a possibility of diabetic ketoacidosis. Yeah, excessive acetoacetic acid can be formed. Why excessive acetoacetic acid? Again you think, very simple, more fatty acids means that can be converted to beta hydroxybutyric acid, acetoacetic acid. All those are nothing but ketones. Yeah, beta oxidation of fatty acids can take place. Acetoacetic acid is more released. Those acetic acid will release acetylcholine. Diabetic ketoacidosis, very, very dangerous condition, immediate admission is needed. So ketosis resulting in acidosis, and that results in acidotic coma. Very, very important. So you should not allow the patient to end up in DKA. Very important. If I am not discussing about kidney, is one of the very important organs of homeostasis. If they ask which is the most important organ of homeostasis, all organs are important, but kidney has a special role. When my blood glucose is more than normal, the excess glucose is expected to be excreted in the kidney. Renal threshold of glucose is 180 mg per deciliter. So if your blood glucose is up to 180 mg, the glucose will not come in the urine. Glucose will not occur. Mellitus means honey, sweet. Diabetes mellitus. Why mellitus? Because if your blood glucose, for example, if your blood glucose is 250, so instead of 180, 70 is more. What happens to the 70 excess glucose? That appears in the urine. So glucose-urea. Yeah, now this is the diagram of omnus octet. Octet means 8. So 8 pathophysiologies which is contributing to hyperglycemia. Hyperglycemia is the main cause of diabetes. Yeah, whenever glucagon is increased, glucagon is hyperglycemic hormone. All hormones are hyperglycemic except insulin. So when glucagon is increased, what happens? Hyperglycemia. When impaired insulin secretion, so far we discussed that only, IRS pathway blocking, insulin resistance, obesity causing insulin resistance, all those things causes hyperglycemia. Decreased incretin, hyperglycemia. If kidney is not excreting and reabsorbing more, then hyperglycemia can occur. And neurotransmitter defect. So skeletal muscle decreased glucose uptake means what? Glucose is not entering into the muscle via GLUT4, so hyperglycemia. So skeletal muscle not taking glucose, hyperglycemia. Incretin not working, hyperglycemia. Adipose tissue not functioning properly, hyperglycemia. Kidney not functioning properly, hyperglycemia. Neurotransmitter dysfunction also causes hyperglycemia. All these, liver definitely, impaired hepatic glucose production, hyperglycemia. Liver acts as a buffer. If liver is problem, all the glucose pathways, gluconeogenesis, glycerol synthesis, glycogenesis, everything is under problem. So liver not functioning properly, hyperglycemia. All these contributes to the omnus octet. 8 mechanisms which can result in hyperglycemia. It's not only insulin, glucagon, all the organs are involved. Yeah, these are the common symptoms which patients comes in diabetes. Why? There is 3 polyuria, polydipsia, polyphagia, acidosis, atherosclerosis. You know the reason. Why polyuria? What happens when your blood glucose is 300 up to 180, kidneys reabsorb, remaining 120 has to come through the urine, but urine cannot excrete glucose as powder. So to excrete that, simple, for the kidneys to excrete that excess glucose, it has to absorb the water also, because glucose, I cannot pass urine as powder, I have to pass urine as a liquid only. So for the kidneys to excrete the dilute urine along with glucose, urine output increases, very simple. So whenever blood glucose increases, there is osmotic diuresis. So glucose is a solute or solvent? It is a solute. When the blood glucose increases, for the glucose to come in the urine, it takes the solvent also, that is called a solvent drag, and that solvent is water. Polyuria, more water is lost in the urine, because water, why more water? For glucose to come out, glucose can come along with water only, glucose cannot come as such as powder. So polyuria concept is clear. Because of polyuria, what happens to your water? Water content is reduced, you are going to suffer from dehydration, cellular dehydration also will be there as water is lost. So to compensate that, I drink more water. Homeostasis, as water is lost in the form of urine, I want to drink more water, so I feel very thirsty. Thirsty is called polydipsia. Why polyphagia? Excessive eating. Yeah, blood glucose is increased. Whether glucose is entering into the cell, whether glucose is entering via GLUT4 into the skeletal muscle, no. Whether glucose is entering into the adipose tissue, no. So your tissues are not getting the required glucose. So where is the energy going to come? So I am deprived of energy. So what? My brain tells, come on, you are deprived of energy, go and eat. So to compensate the unutilization of glucose, I try to eat more. That is called a polyphagia. So excessive urination, excessive thirst, excessive eating. AG, advanced glycosylated end products. So hemoglobin, if your blood glucose is increased too much, that excess glucose sometimes bind with HB, hemoglobin. That is called HbA. That's what HbA1c is. 3 months average blood glucose we tell usually. Usually you do fasting postprandial. There is another test along with fasting postprandial, HbA1c. What happens whenever there is increase in blood glucose, that excess glucose sometimes binds with hemoglobin, RBC. Hemoglobin is a molecule present within the RBC. Lifespan of RBC is usually 120 days. So until that RBC lifespan, if there is increased glucose, that glucose can bind with that hemoglobin. That hemoglobin is called glycosylated hemoglobin. My question is, when glycosylated hemoglobin is going to be more? Whenever blood glucose is more. That binded products is called as advanced glycation end products. This excess glucose goes and binds with amino acids within the proteins. One is hemoglobin, which is a protein. And these excess advanced glycosylated end products can also bind to specific receptors on endothelial cells in blood vessels. So apart from the fat metabolism which I discussed, that's another mechanism which is very important. This AG is these glucose molecules bound with some proteins now. So protein glucose has bound. These bounded molecules can enter to the receptors of endothelial cells in blood vessels, which triggers the formation of procoagulants, reactive oxygen species, and synthesis of atherosclerotic products. Peripheral neuropathy can occur. Again, nerve muscle also does not receive the required energy in the form of glucose. Not going to treat diabetes, you end up in metabolic syndrome. If you are not going to control your blood glucose, triglycerides will increase, HbA1c, that advanced reactive end products will increase, atherosclerosis will increase, coronary heart disease will increase, complications, macrovascular complications. Macro is heart problems, all those things. Micro is three pathies, neuropathy, nephropathy, retinopathy. This is one of the important slide in pathophysiology of diabetes mellitus. This is the interaction of pathophysiology and diabetes, almost the same omnus octet only. Insulin resistance, relative insulin deficiency, increased hepatic glucose, increased glucose reabsorption from the kidney, incretin defect, alpha cell defect. Same difference of omnus octet only. Interaction, all these together contribute. Very, very important. That's what we have to treat as early as possible. Always remember, treat the diabetes as early as possible. Once you come to this stage, see, up to 4 to 7 years, see, everything seems to be, beta cell seems to be functional. Now just see here, glucose production starts increasing. Hepatic glucose production up to 4 to 7 years of diabetes is okay. But then what happens? Your hepatic glucose production is going. Now just concentrate the insulin secretion. Yeah, this is increase is okay. You are able to manage. But here what happens? Insulin secretion decreases because your beta cell is exhausted. How long the beta cell will keep on secreting insulin? You have to control your blood glucose. If you are not controlling your blood glucose, somewhat beta cells tries to function by secreting insulin, like I mentioned, night time. Insulin should be at rest, but beta cells will secrete if you are going to eat at night. If you keep on blood glucose not controlled, at one stage beta cells exhaustion takes place. This is called a beta cell fatigue. There, even in type 2 diabetes, you have to give insulin only, no other go, because beta cells is not going to function. Here itself insulin resistance starts. Up to this okay, but after 4 to 5, 7 years, insulin resistance starts. What I want to say is, initial stages of diabetes, if you are diagnosing it early, beta cell is functioning well, insulin resistance you can try to control, hepatic glucose production is okay. But once you come here, after some functional beta cells here, yellow color, the beta cell function is also decreasing, insulin secretion is also decreasing, hepatic glucose production is also increasing, insulin resistance is also coming. So treat here itself. We call it as eat early, eat hard. So try to control your blood glucose as early as possible, try to diagnose it as early as possible. But the problems here, most of us are diagnosing here only after 4 to 7 years. That's a big problem. That's why we are diabetic capital, and most of us, in spite of knowing how to control, we are not able to bring it in control because diagnosis itself is very, very late. I am showing how various drugs act on this omnus octet. In fact, abnormal fat metabolism is more dangerous than carbohydrate. Omnus octet, very, 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 very important. 2 slides I showed, omnus octet, the 8 pathologies that contributes to hyperglycemia, and I discussed about symptoms and signs, polyuria, polyphagia, polydipsia, how it occurs. About DK also we discussed, diabetic ketoacidosis, and thank you. Speak on pathophysiology of diabetes mellitus. Thank you once again.